positive patient response to a structured exercise program delivered in inpatient psychiatry. David Tomasi, Sherry Gates, Emily Ryans. Background. The complexity of diagnostic presentation of an inpatient psychiatry population requires an integrative approach to health and well-being. In this sense, the primary need of this research aims at developing clinical strategies and healthier coping skills for anger, anxiety, and depression, promoting self-esteem, healthier sleep, and anxiety reduction, as well as enhancing mood and emotional behavior regulation via exercise and nutrition education. Objectives. The primary objective is to promote exercise, fitness, and physical health in inpatient psychiatric patients. The secondary objective includes therapeutic management of depressive symptoms and patient-centered approach to mania, angry outbursts, and generalized disruptive behavior. The tertiary objective is promoting research into the psychophysiological factors of exercise and nutrition education in combination with psychotherapy. Method. Monitoring self-reported changes in mood and general well-being via administration of surveys and questionnaires pre- and post-exercise sessions. Results. The research yielded positive outcomes in all areas investigated, suggesting the positive effects of exercise and mind-body strategies in the context of psychotherapy in inpatient psychiatry. Conclusion. Physical exercise may be a helpful way to reduce mental health disorders in the context of inpatient psychiatry by targeting anxiety, depression, anger, psychomotor agitation, and muscle tension, and addressing stressors and triggers, and to develop a more balanced and integrated sense of self. Introduction. Multiple studies have indicated that a multidisciplinary approach focused on mind-body connection has been instrumental in promoting well-being in the general population. In the context of inpatient psychiatry, the specific needs of complex diagnostic presentation represent a challenge to a commonly utilized combination of psychotherapy and pharmacological intervention. To respond to this need, this research aimed at implementing this approach through the application of exercise and nutrition education session. In this context, mind-body flexibility indicates the ability for an effective form of therapeutic intervention to promote more empowering, dynamic, dialectic, holistic, and adaptive psychological, cognitive, and physical somatosensory strategies to well-being. Intervention. General description. Psychotherapists, group therapists, GTs, offer exercise groups followed by nutrition education sessions to patients on the inpatient psychiatry units Shepardson 3 and Shepardson 6 at the University of Vermont, UVM, Medical Center 4 times a week. Each 60-minute exercise session consists in a combination of cardiovascular training, resistance training, and flexibility developed inclusive of A. Free body exercises, B. Stretching and strengthening exercises, and C. Muscle activation specific fitness equipment such as upright and recumbent bikes, ellipticals, standard rowers and water rowers, push-up bars and stands, Bosu balance trainers, exercise balls, handheld fitness balls, balance pods, and aerobic steps. Furthermore, each exercise session was created following safety versus effectiveness fitness parameters according to the international guidelines in the current scientific literature, as well as a general recommendation from the American College of Sports Medicine, followed by a discussion with the therapist and the student or intern. The 60 minutes nutrition education sessions consist of identifying food groups, clarifying healthy food choices, discussing budgeting, and developing meal preparation and planning, according to the most recent recommendation in the scientific literature on the connection between gastrointestinal health and psychological well-being. The session also facilitated discussions around the challenges of maintaining a healthy lifestyle, with fluctuating psychiatric concerns attributed to cognitive functioning. All aspects of physical and psychological education interventions have been developed from a patient-centered perspective, taking into account the specific diagnostic parameters for each individual enrolled in the study. Measure of fitness, walk tests were not collected in order to present an individual-focused assessment. The latter is especially relevant given the possible negative influence of standardized expectation in the case of normal values for expected steps, physical performance and fitness, to value of self-image and self-esteem in major depressive disorder (MDD) patients, especially in the context of comparative analysis inclusive of a control group. Primary workflow. GTs administer pre-service to patients at the beginning of each session and assist students, volunteers in having patients fill out surveys. GTs also collected the post-surveys at the end of each session and placed in the appropriate collection box. Prior to patient's discharge, further recommendation based on interaction with patients in the exercise and nutrition education groups have been delivered to patients in the form of individual consultation, as well as printed manual with individualized descriptions developed by the GTs in collaboration with the University of Vermont students' intern. Timeline. Communication explained the research, including Health Insurance Portability and Codability Act, HIPAA rules and regulation, medical ethics parameters, Institution Review Board Clinical Research Center approval, and informed consent paperwork has been emailed to and further discussed in person with all interest parties prior to the start of the study. The length of the study has been 12 months on both inpatient psychiatry units Shepardson 3 and Shepardson 6. Methods, population, and eligibility. Eligibility criteria include adult patients older than 18 years old, number 100, on the inpatient psychiatry units Shepardson 3 and Shepardson 6, UVM Medical Center, over a 12-month study period. Qualitative and quantitative analysis. The pre- and post-session surveys address overall mood, willingness to engage in further education, physical condition, physical fitness, readiness, and movement-based practices, nutrition group attendance, and perceived body image, using a combination of binary, yes/no responses, and Likert type scales with reported percentages and p-value from McNamara test and p-value from Wilcoxon-Segment rank test. The link of question the service administered to patients with relative percentages and statistically relevant annotation is reported in Table 1. List of questions in patient-administered surveys with relative percentage and statistically relevant annotations. Objective data have not been collected at this stage, as it will have to be directly linked to patients' identifiers, including diagnostic background and medical history. Furthermore, the researchers in this study wanted to limit the possible negative effects of bias, both from patients' and providers' perspective, in collecting this type of data. The researchers are planning to expand the study in the near future in order to include measurable biological data inclusive of patient-specific vitals. Inclusion criteria. At the beginning of each exercise and nutrition group, the group therapist, the registered nurse, or mental health technicians read the informed consent information and procedure to the patients. Following informed consent documentation, every patient had the option to decline to take part in the exercise and nutrition education group. The total time allowed to complete both exercise and survey from beginning to end was 60 minutes. Withdrawal procedures. Following informed consent documentation, every patient had the option to decline to fill out the research survey. 15 minutes before the beginning of each group, the group therapist, registered nurse, or mental health tech asked patients to decide whether they wanted to take part in the group. Each GT, RN, or MHT actively monitored the activity and the safety of patients and environment, interrupting the regular process of the group when necessary. Conditions such as an environment within the group and on the unit affecting the modification of the study have been taken into consideration. Each GT, RN, or MHT had also the option to make the decision not to invite one or more patients to the group or interrupt the group, terminating the study, if such situation arose to be clinically or medically inappropriate. Safety, privacy, and consent. All the information has been collected without any identifiers and used only for statistical purposes, and it will not be connected or linkable to clinical medical records of single patients and/or groups, categories, diagnosis in the future. The hard copy data have been archived in the log GT office on Shepardson 529, separated from both inpatient psychiatry units Shepardson 3 and Shepardson 6. Each GT, RN, or MHT documented on paper the number of patients participating in the group, and the number of patients absent or patients who declined to take part in the group. Results. Examine the data obtained by analyzing patients' responses in the administered pre- and post-session surveys we were able to identify multiple positive outcomes as direct results of the implementation of physical exercise and nutrition education in patient psychiatry. In this analysis, the specific differences in terms of diagnostic presentation between Shepardson 3 and Shepardson 6 have to be taken into account in our attempt to better understand, from an epidemiological viewpoint, the levels of cognitive strength, understanding, and ability versus capacity demonstrated in the responses provided. To give a more detailed context, Shepardson 3 presents a patient population with DSM-5 psychiatric diagnosis ranging from MDD, bipolar affective disorders, BPD 1 or 2, borderline personality disorders, mood disorders, and generalized anxiety disorders, often in association with other specified and unspecified psychiatric versus general medical issues and comorbidities. The same applies to Shepardson 6, although in this case, the most common diagnoses are schizophrenia, schizoaffective disorder, schizotypal and schizoid personality disorders, and psychosis. There are certainly overlaps between the two inpatient psychiatry units, spanning from paranoid and manic presentation to a lesser extent catatonia and suicidality, whether in the form of active intent or ideation. These aspects are reflected in some of the answers pertaining to the perceived effectiveness or helpfulness of the interventions offered. The analysis of the results obtained yield a clear idea on the patient perceived positive changes in both psychological and physical terms. On the Shepardson 3 unit, to the question, did exercise group improve your mood? 93.2% of patients respond affirmatively. For, are you pleased with the way your body feels now? The positive response amounted to 93.0%. Table 1. Very similar outcomes for Shepardson 6 with 90.6% for, are you pleased with the way your body feels now? And 96.8% for, did the exercise group improve your mood? Another very important aspect is found in the future-oriented motivation strategies thereby implemented, with the majority of subjects expressing interest in continuing a fitness routine. This is exemplified in the affirmative answer to, after attending this group, do you think you will exercise more? With 97.6% for Shepardson 3 and the totality of patients on Shepardson 6, 100.0%. Table 1. The willingness and readiness of patients to make room for physical exercise in their therapeutic schedule has resulted in an overall positive outcome for the therapeutic environment as a whole. This also presented the advantage of better scheduling strategies for the therapeutic offerings in both units. In particular, classic cognitive behavioral and dialectic behavioral psychotherapy modalities combined with integrated approaches such as exercise and nutrition, beside the already offered approaches such as art therapy, mindfulness meditation, Tai Chi Chuan, music therapy, etc., corroborate the general amelioration of increased well-being following each session, as in well-established multidisciplinary models. This provides evidence from a mind-body perspective already utilized effectively in patient psychiatry. Furthermore, the development of an exercise space provides an improvement from the perspective of a more therapeutically nurturing environment. In particular, having an exercise room with natural light and natural scenery-based tiles and decoration specifically recognized for this study support a more balanced and positive atmosphere as evidenced by research, especially given the fact that the inpatient psychiatry unit does not have any source of natural light beside relatively small windows in patient rooms, in shared therapeutic areas or any open spaces where to socialize and interact. The implementation of exercise and nutrition education also contributed to a better interaction with a multidisciplinary treatment team, psychotherapists, psychiatrists, nurses, and social workers, and between departments, particularly thanks to the internship and volunteering opportunities from UVM students in the fields, academic departments of exercise and movement science, psychology, medicine, nursing, social work, and human development, who took active part in the exercise sessions, as evidenced by the analysis reported in the Patient Provider Satisfaction Survey and Focus Group, inclusive of all multidisciplinary treatment team members. Moreover, this strategy also benefited patients and community at large via the development of health-improving strategies for outpatient activities. From the perspective of patient satisfaction and responses, mood ratings, before and after, perceived physical conditions, and the connection to general well-being and differential diagnosis have been described through positive correlations in the graphs, figures 1, 4, and table 1. Discussion and conclusion. Confirming the results from multiple studies, physical exercise and nutrition education may be a helpful way to reduce symptomatologies linked to mental health disorders in the context of inpatient psychiatry by targeting anxiety, depression, anger, psychomotor agitation, and muscle tension, and addressing stressors and triggers, and to develop a more balanced and integrated sense of self. The achieved improved state of mind-body flexibility, which could be simplified as changing body via changing mind, and vice versa, allow patients to better understand, monitor, and control their psychophysical well-being. Of course, the intrinsic therapeutic value of patient-provider relationship remains essential for positive outcomes in this setting. This is especially true in the case of therapeutic interventions based on the notion of leading by example, whereby informed practices supported by evidence-based scientific recommendation, in our case, not only in areas of psychological assessment and treatment, but more specifically in physical exercise and nutrition, are directly demonstrated in person to the patient in the context of a group setting. Beyond standard deviation and outliers and other variables, including statistically relevant factors within the placebo versus nocebo effect parameters, are therefore important to emphasize the importance of positive reinforcement in the form of empowering, self-nurturing, self-awareness raising strategies common to standard practices in positive psychology, motivational interviewing, and health wellness coaching. Limitations. The primary limitation of this study were the relatively small sample size, 100, versus specificity of inpatient psychiatric population, psychiatric versus general medical needs, non-diagnostic identifiers. Less significant limitations included 1. Room space restriction due to the architectural structure of the inpatient psychiatry units where the study has been conducted. 2. Variation differences in attendance rates and survey completion due to psychophysical comorbidities and complications. And 3. Ontologically relevant factors connect to the complexity of diagnostic presentation and their effect on the ability to interact and respond appropriately to the expectation of both exercise and nutrition sessions. Future studies. In addition to verifying the reliability of the results and outcomes, evidence via surveys and questionnaires administered to the patient population in larger groups over a longer course of treatment, also inclusive of the same level of comparative analysis provided by focus group research studies and in monitoring patient-provider relationship across multidisciplinary treatment team members, more studies will be needed to better identify specific exercise types, sets, repetitions, routines, as well as specific nutrition versus dietary recommendations, particularly in the context of individualized, patient-centered strategies, which takes into account physical structures, strengths, and limitation, as well as ethnic, cultural, and religious backgrounds. Acknowledgements. Gratitude extend to all staff, students, and faculty at the University of Vermont and the University of Vermont Medical Center. Declaration of conflicting interests. The authors declared no potential conflicts of interest with respect to the research, authorships, and/or publication of this article. Funding. The authors disclosed receipt of the following financial support for the research, authorship, and/or publication of this article. The authors were awarded the University of Vermont Medical Center research grant through the UVM Medical Center Fund as financial support for their research, in particular the development, construction work, and purchase of fitness equipment, and for the dedicated fitness area in inpatient psychiatry. SAGE Journals. Global Advances in Health and Medicine. Academic Consortium for Integrative Medicine and Health. Positive patient response to a structured exercise program delivering patient psychiatry. David Tomasi, Sherry Gates, and Emily Ryans.